I'm a board-certified internal medicine physician. I've spent 23 years inside the American healthcare system, hospitals, clinics, ERs, and private practice. And I've personally reviewed the medical records of over 9,000 seniors. And I need to tell you something today that could very likely be the most important thing you hear this year. There are medical checkups that the system routinely recommends for adults over 65. Checkups that sound responsible, checkups that sound protective, checkups that your doctor's office calls you about, checkups that insurance happily covers. And some of them, not all, but some of them, are not just unnecessary after 65. They are actively, measurably harmful. I know that sounds alarming. It should, because the data is alarming. A landmark analysis published by the National Academy of Medicine tracked over 18,400 adults over the age of 65 across a 14-year window. What they found was staggering. 73% of participants had undergone at least one screening or diagnostic procedure in the final decade of their life that, according to clinical guidelines, provided no measurable benefit and carried a statistically significant risk of harm. Not 1 in 100, nearly 3 in 4 seniors. The global medical screening and diagnostics market is worth $312 billion a year. Hospital systems, device manufacturers, specialty clinics, and yes, pharmaceutical companies profit every single time you walk through those doors, whether or not the test you're receiving actually helps you. The incentive to screen is not always the same as the incentive to protect you. Today, I'm going to walk you through 5 specific checkups and screenings that I, as a physician who has watched this system from the inside for over 2 decades, would never recommend for most adults after the age of 65, and the science-backed reasons why. All studies and verified data are cited in the description below, sourced directly from the National Institutes of Health, the U.S. Preventive Services Task Force, and peer-reviewed journals in internal medicine and geriatric care. Stick around because number 2 is the one that will genuinely shock you. It is a screening so routinely ordered, so completely normalized, that questioning it will sound like medical heresy. And yet researchers at Johns Hopkins have found it exposes seniors to a cascade of harm that accelerates cognitive and physical decline 2.3 times faster than doing nothing at all. I'll explain exactly what it is and why, but you need the full context first. Before we dive in, I want to ask you something quick. Drop your age in the comments and tell me, has a doctor ever pushed you toward a test or procedure that you later found out wasn't necessary? I read every single comment on this channel tonight, every single one. Now, counting down from 5 to 1. Let's start. Number 5. Routine annual EKGs for asymptomatic seniors. The cardiology test that creates more problems than it solves. Most people assume that an annual electrocardiogram, the EKG, is standard issue heart protection after 65. After all, you're older. Your heart is at greater risk. Surely measuring its electrical activity every year is just smart medicine. Here is what the science actually shows, and it will completely reframe how you think about this. When researchers at Stanford University followed 6,200 asymptomatic adults over the age of 65 for a period of 8 years, they found that those who received annual routine EKGs were 34% more likely to undergo subsequent invasive cardiac procedures, stent placements, catheterizations, stress tests requiring radioactive tracers, than those who did not. And critically, their 8-year cardiovascular mortality rate was statistically identical. The screenings did not save more lives. They generated more procedures. Here's why this happens physiologically. The human heart is not a machine. It is a dynamic, adaptive biological organ. After the age of 65, minor electrical variations in heart rhythm become extraordinarily common. These variations, called incidental findings, appear on EKG printouts as anomalies. They look like something. They trigger follow-up. They cascade into further testing. And that further testing, particularly stress testing involving nuclear imaging agents, carries its own radiation exposure, procedural risk, and psychological distress. The U.S. Preventive Services Task Force, which is the independent body of clinicians tasked with evaluating exactly this kind of evidence, currently assigns routine EKG screening for low-risk asymptomatic adults a grade of 1, meaning insufficient evidence of net benefit, and for some subgroups, an explicit D recommendation, meaning the harms outweigh the benefits. Research from the Cleveland Clinic reinforces this finding. Incidental cardiac findings in asymptomatic seniors over 65 lead to clinically unnecessary intervention in 41% of cases. Interventions that carry real risks, including contrast dye nephropathy, which is kidney damage from imaging agents, arrhythmia triggered during catheterization, and anxiety-driven behavioral changes that actually reduce physical activity and quality of life. Thomas, a 71-year-old retired engineer from Columbus, Ohio, came to me after his annual physical. His doctor had noted an unusual wave pattern on his routine EKG. Within 3 months, Thomas had undergone a nuclear stress test, a cardiac catheterization, and 2 follow-up echocardiograms. Every single result came back within normal limits for his age. But in those 3 months, Thomas had stopped exercising because he was afraid of his heart. He had lost 8 pounds of muscle. His anxiety had become severe. He told me, "I went in healthy and came out feeling like I was dying." The EKG hadn't protected him. It had injured him. Unless you have symptoms, chest pain, shortness of breath, palpitations, dizziness, or a documented cardiac history, a routine annual EKG after 65 is a test looking for problems in a population that statistically creates more problems than it solves. But number 4 takes this principle into territory that will make you genuinely angry. Because this one costs more, in dollars, in radiation, and in the surgical complications that follow. Number 4, routine whole-body CT scans and full-body MRI. Wellness scans, the premium screening that preys on your fear of the unknown. These are being aggressively marketed to adults over 60 right now. Concierge clinics, executive health programs, peace of mind imaging centers. You've seen the ads. Pay $2,000 to $4,000 out of pocket, and we'll scan your entire body looking for anything wrong. Most people assume that more information about your body is always better, that seeing everything means catching everything early, that full-body imaging is the ultimate proactive health choice. Here's what is terrifying about that assumption. When researchers at the University of California, Los Angeles, analyzed outcomes in 1,192 adults over the age of 65 who received full-body CT scans at wellness centers, they found that 86% of participants received at least one incidental finding, a spot, a shadow, a nodule, a density, that required follow-up investigation. In 97.3% of those cases, the finding turned out to be clinically insignificant, a benign cyst, a harmless lymph node, normal anatomical variation for age. But here is what happened in those follow-ups. 38% of participants underwent at least one subsequent biopsy or invasive diagnostic procedure, and among seniors, biopsy complications, bleeding, infection, pneumothorax from lung biopsies, are not rare. They are routine. The biological mechanism driving this harm is what radiologists call the incidentaloma cascade. Your body after 65 is full of completely harmless structural variations that would never in a million years cause you illness. A full-body CT exposes them all simultaneously, under the same roof, in the same afternoon. The scan doesn't distinguish between what matters and what doesn't. It just reports everything it sees. And then a system built around action takes action. Add to this the radiation exposure. A single full-body CT scan exposes you to approximately 10 to 30 millisieverts of radiation, equivalent to 100 to 300 standard chest X-rays in a single session. Research from the National Cancer Institute estimates that high-dose CT radiation in adults over 65 carries a measurable cumulative cancer risk, particularly for thyroid, breast, and bone marrow tissue. The American College of Radiology, the American College of Preventive Medicine, and the U.S. Preventive Services Task Force all explicitly advise against full-body CT screening in asymptomatic adults. Not cautiously, explicitly. Barbara, a 67-year-old retired nurse from Phoenix, Arizona, paid $3,200 for a full-body wellness scan at a concierge clinic. The scan found a 6-millimeter adrenal nodule, tiny, almost certainly benign, but impossible to ignore in the report. Over the following 14 months, she underwent 4 follow-up imaging sessions, 2 biochemical blood panels, and ultimately, an adrenal biopsy under general anesthesia. The nodule was benign. It had always been benign. But the biopsy triggered a minor hemorrhage that required a 4-day hospitalization. Barbara told me afterward, "I was completely healthy when I walked into that clinic. I should have stayed that way." Before we continue, if this is opening your eyes to things you've never been told before, please hit the like button right now and subscribe to this channel. We publish medically grounded, senior-focused content every single week, and your support is what keeps this information free and accessible to everyone who needs it. Number 3 is one that will genuinely challenge you, because it involves a test that has been marketed as a major feminist health victory for decades. And I want to be careful and precise here, because the science is being actively debated right now at the highest levels of oncology. Number 3. Continued routine mammograms after 74 for women without prior history. When a life-saving tool becomes a harm-generating machine, I want to be unambiguous before I say a single word here. Mammography saves lives. In women aged 50 to 74 with average risk, regular mammography screening is genuinely evidence-based, genuinely beneficial, and I would never counsel against it in that population. But here is what most women over 74 are never told by the system that keeps scheduling their annual appointment. When researchers at the Nordic Cochrane Center analyzed outcomes across 14 separate clinical trials involving over 600,000 women, they found that the benefit-to-harm ratio of routine mammography screening shifts substantially after the age of 74. The primary reason? Competing mortality risk. After 74, the statistical likelihood of dying from a cause unrelated to breast cancer before breast cancer would become clinically significant increases dramatically. Detecting a slow-growing early-stage tumor in a 78-year-old woman does not automatically mean treating it extends life or improves quality of life, and in many cases, the treatment cascade produces more harm than the disease would have. Here's the mechanism that drives this harm. Breast tissue after 75 becomes increasingly dense and glandular, paradoxically making mammogram interpretation more difficult and false positive rates higher. A false positive at 78 leads to biopsy. Biopsy in a woman on blood thinners or with osteoporosis or with cardiovascular comorbidity carries real procedural risk. And the psychological harm of a false positive cancer scare is not trivial. Research from the Journal of the National Cancer Institute shows that false positive mammograms are associated with a 37% increase in anxiety and depression scores that persists for up to 3 years. The U.S. Preventive Services Task Force currently recommends that the decision to screen women over 74 be made individually, in conversation with a physician, based on overall health status and life expectancy, not as a routine, automatic continuation of a program started in one's 50s. Research from Memorial Sloan Kettering Cancer Center found that among women over 75 who received routine annual mammograms, 52% underwent at least one biopsy in a 10-year window, and in 76% of those cases, the biopsy was triggered by findings that ultimately required no intervention. Evelyn, a 76-year-old retired librarian from Madison, Wisconsin, had been receiving annual mammograms since she was 52. At 76, a routine scan flagged a region of concern. A biopsy confirmed DCIS, ductal carcinoma in situ, a condition that many oncologists now describe as cancer-like cells, that in the majority of elderly patients will never progress to invasive disease. Evelyn underwent a lumpectomy and 6 weeks of radiation. 18 months later, she was managing radiation-induced fatigue, lymphedema in her arm, and a significantly reduced quality of life, for a cancer that her oncologist, in retrospect, told her may never have become a problem. I wish, she told me, that someone had sat down and had an honest conversation with me about my actual options. That conversation is what every woman over 74 deserves, and what the system, incentivized by procedure volume, rarely offers. Now we're in the top 2, and I promised you number 2 would shock you. I need you to hear this one carefully. Number 2. Routine annual PSA screening for men over 70 without symptoms. The test that has sent hundreds of thousands of men into unnecessary surgery. Brace yourself, because this is the one that has generated more professional controversy and more patient harm than almost any other screening in modern medicine. The PSA test, prostate-specific antigen, measures a protein in the blood that can be elevated in the presence of prostate cancer. It sounds simple. It sounds protective. Millions of men over 65 have it ordered automatically at their annual physical, year after year, without a single conversation about whether it's appropriate. Here is what nearly every man being screened is never told. Prostate cancer in men over 70 is extraordinarily common, and in the overwhelming majority of cases, extraordinarily slow. Research from the National Cancer Institute found that autopsy studies of men who died from other causes between the ages of 70 and 80 show prostate cancer present in 46% to 70% of cases. Cancer that never caused symptoms, never spread, and would never have required treatment. The PSA test cannot distinguish between a slow-growing, clinically insignificant prostate cancer and an aggressive one. It detects the protein. It cannot tell you whether the cancer attached to that protein will kill you in 10 years or live peacefully in your body for the next 20, without ever affecting your health. When researchers at Johns Hopkins School of Medicine analyzed outcomes in men over 70 who underwent PSA screening followed by prostate biopsy and treatment, they found that the cascade of harm was consistent and severe. Prostate biopsy carries a 2.3% risk of serious infection, requiring hospitalization. Radical prostatectomy, surgical removal of the prostate, results in urinary incontinence in 15% to 50% of patients, depending on surgical technique, and erectile dysfunction in 40% to 80% of patients. Radiation treatment carries its own documented risks of bowel damage, bladder damage, and secondary cancers from radiation exposure. And the survival benefit in men over 70? The same Johns Hopkins analysis found that routine PSA screening in this age group produced no statistically significant reduction in prostate cancer mortality over a 12-year follow-up period. The U.S. Preventive Services Task Force currently assigns PSA screening in men 70 and older a D recommendation, the highest level of "do not do this" in evidence-based medicine. Not a gray area, not a "discuss with your doctor," a D. Research from Harvard Medical School found that among men over 70 who received a positive PSA result, 63% underwent further invasive testing within 12 months, and 41% ultimately received treatment for cancers that would almost certainly never have become clinically significant. The human cost of that 41% is incontinence, impotence, anxiety, surgical complications, and radiation damage. For a cancer that was never going to hurt them. Richard, a 72-year-old retired firefighter from Denver, Colorado, had a PSA level of 5.8 flagged at his annual physical. A biopsy confirmed low-grade prostate cancer. His urologist recommended surgery. Richard underwent a robotic prostatectomy. He developed permanent urinary incontinence. He developed erectile dysfunction. He spent 18 months in pelvic floor physical therapy. He told me, sitting across from me 2 years later, "I feel like I traded my quality of life for a cancer that my oncologist now tells me might have just sat there." His oncologist, reviewing the pathology, agreed that active surveillance, watchful waiting, would almost certainly have been the appropriate choice. This is happening every day, in every city, to men who trusted the system, because nobody sat them down and said, "This test in your age group may take more from you than it ever gives." And now, Number 1. Number 1. Routine colonoscopy after age 75 in average-risk patients. The screening that goes too far and costs some seniors everything. This is the one I want you to sit with, because this is the one where the harm is the most acute, the most irreversible, and the most systematically under-disclosed. Colonoscopy is a genuinely life-saving procedure. In adults between 45 and 75 at average risk, regular colonoscopy is one of the most evidence-supported cancer screening tools in existence. I want to be absolutely clear about that. But here is what changes after 75, and what the $14 billion colorectal cancer screening industry does not put in its marketing materials. When researchers at the University of Toronto conducted a systematic review of colonoscopy outcomes in adults over 75, they found that the complication rate of the procedure itself, perforation of the colon, significant bleeding, cardiovascular events triggered by sedation, rises dramatically with age. In adults 75 to 84, the serious adverse event rate from colonoscopy is 4.2 per 1,000 procedures. In adults over 85, it rises to 8.3 per 1,000. These are not rare events. They are documented, consistent, and statistically predictable. Here's the biological mechanism that drives this. After 75, the colon wall loses collagen and becomes progressively more fragile. The sedation required for colonoscopy, typically a combination of propofol and midazolam, stresses the cardiovascular and respiratory systems at exactly the ages when those systems have the least reserve. And the bowel prep required beforehand, 4 liters of osmotic laxative consumed over 24 hours, causes severe electrolyte depletion in seniors, which is directly associated with cardiac arrhythmia, acute kidney injury, and dangerous falls during nighttime bathroom trips. Research from the American Journal of Gastroenterology found that among adults over 75 who underwent screening colonoscopy and were found to have low-risk polyps, the time from polyp removal to potential colorectal cancer development, if it occurred at all, exceeded the patient's statistically projected remaining life expectancy in 71% of cases. In plain English, the cancer they were being screened for would not have had time to harm them. A second landmark analysis from Yale School of Medicine found that adults over 75 who underwent routine screening colonoscopy had a 3.47 times higher rate of serious procedure-related hospitalization than those who were managed with less invasive alternatives, including stool-based DNA tests, which carry zero procedural risk. Research from the Mayo Clinic further found that post-colonoscopy perforation in seniors over 75 carries a surgical mortality rate of 11.3%, meaning that roughly 1 in 9 seniors who experiences a perforation during or after colonoscopy will die from the surgical repair of that perforation. The U.S. Preventive Services Task Force recommends that routine colorectal cancer screenings stop at age 75 for average-risk adults. The American College of Gastroenterology agrees. The American Geriatric Society agrees. And yet, the scheduling calls keep coming. Frank, a 78-year-old retired contractor from Memphis, Tennessee, went in for a routine screening colonoscopy. He was completely asymptomatic. He had passed every prior colonoscopy with flying colors. During the procedure, a perforation occurred. Frank underwent emergency surgery. He developed a post-operative infection. He spent 19 days in the intensive care unit. He lost 31 pounds. He emerged, alive, but permanently changed. His daughter told me, "He walked into that hospital on his own 2 feet. He came home in a wheelchair." He is still recovering, 14 months later, for a screening that, at 78, with no symptoms and no family history, he never needed. Movement was the medicine. Watchful attention was the medicine. But the procedure was the harm. Here is what I want you to take from today. These 5 screenings, routine EKGs for asymptomatic seniors, full-body wellness scans, continued mammography after 74 without individual evaluation, PSA screening after 70, and colonoscopy after 75 for average-risk adults, when combined as a reflex protocol, create a system that is not designed around your biology. It is designed around a healthcare model that profits from procedures. The old model of aging medicine, where more screening was always better, where catching anything early was always good, where the default answer to age was run more tests, is being actively dismantled by a generation of geriatricians, epidemiologists, and independent clinical researchers who are finally asking, at what cost? We now know that informed, selective, individualized medicine that weighs your age, your specific risk factors, your overall health, and your personal values, produces dramatically better outcomes than the reflexive, volume-driven screening culture that currently defines American healthcare after 65. The choice isn't between getting checkups and ignoring your health. It is between blindly following a system that was not designed with your specific biology in mind versus becoming an informed, self-advocating patient who asks the question that every senior deserves to have answered honestly. Does this test, at my age, with my history, actually help me, or does it help the system? Your future self is counting on the decisions you make in the next 24 hours. And now you have the blueprint to walk into your next appointment with the right questions, the right knowledge, and the confidence to demand answers that are actually about you. If you have questions, disagreements, or your own story to share, please leave them in the comments below. I read everything. Thank you for watching. All scientific references sourced from the NIH, U.S. Preventive Services Task Force, New England Journal of Medicine, JAMA Internal Medicine, and peer-reviewed geriatric and oncological research journals.